Now Caroline, as I said, this is her last day of medical school. And I thought it might be interesting to just let her talk about what she sees about holonomics and how, as she goes off into her residency and so on, she sees this information is going to help her as a doctor.
I think I have a unique value and tie to your holonomics model because it served me when the traditional model did not. So I'd be happy to kind of share that story if you'd like. I was in the traditional medical system for about 2.5 years with a lot of different problems. Bowel trouble, skin problems, couldn't gain weight, and some brain fog, and ultimately some depression from having all of these symptoms for so long. And the traditional model couldn't really figure out what was going on, and so they just started to blame me.
Now, were you in medical school yet when this happened?
This started before medical school, and I couldn't get a diagnosis through traditional allopathic system. So I started medical school sick, not really knowing what was wrong with me, but being told this is kind of my quality of life right now.
And that brings up another thing, which is that this is not unusual. 5 out of 6 people have immune dysfunction, and many of them are medical students. And as they move into hospitals and are around sick people, the chances of becoming contaminated are real. But what I found is that there's a subset of medical students who have these symptoms of brain fog and autoimmune problems that don't realize what is really causing them. And I think that was what was happening for Caroline when she first came to me as a patient, not just as a student. Now, you ran across me as a practitioner, as a student,
yes,
correct?
One of my professors, as an osteopathic physician, was palpating my back during a basic skills assessment and found something in his physical exam that prompted him to ask me to come into his office afterwards. And I thought I had just bombed the basic skills exam. But when I came back into his office, he said, "Caroline, you're sick." I said, "I know, but my hospital and my doctor don't really know what's going on." And so they told me antidepressants or nothing.
Mm-hmm.
And I didn't really want to go down that road.
Mm-hmm.
At which point, in that same meeting, he picked up the phone and called your office and said, I have a patient for you and you need to see her.
Mm-hmm.
In that same session, I sent you my records and I got into your office, I think, within 3 or 4 days.
Mm-hmm.
And I remember walking in and you saying, "I read all your records. I'm pretty sure I know that you have a gut infection that's triggering all these other immune problems for you. You haven't been doing your yoga, and you really need to work on your relationship issues." And everything you said was accurate. I didn't want to admit to half of it, but you had taken a different look at all the data that had already been gathered.
Mm-hmm.
And then you assessed me briefly as I walked in the room. And in that assessment, you were able to see my posture, you were able to see my emotional contraction, and you were able to see physical signs of autoimmune dysfunction. And
did it help you?
Tremendously. It was not an easy path back towards health
Mm-hmm.
and away from dysfunction, but you provided an explanation and a treatment modality to become one with my physical, mental, and emotional self.
Now, as a medical student who was steeped in the basic science information, like in microbiology and virology and so forth, and immunology, how did you find the information that was presented to you using those ideas holonomically in your treatment? I mean,
I found them very consistent.
Did it conflict with how
No,
you were
if
taught?
anything, it made more sense. I have a background in environmental education, so I'm used to looking at environmental systems
Mm-hmm.
and how those different systems interplay.
But these other practitioners had not factored in any of those matters.
I was not asked about my local environment. I was not asked about emotional stressors. I was not asked about previous trauma in my life,
Mm-hmm.
about why I might be susceptible to a certain infection or process.
Had anyone correlated these other things like the arthralgias or so on with the liver congestion? Did anybody mention that your liver was congested or
No,
sore? How did they tell you about your back pain? How was
I
your
had
back
an
pain?
intussusception that we were able to catch on film. So this is part of the inflammation from a chronic bowel infection for 2.5 years was creating either plaques or complexes of immunes that
And
were
what-
actually
Right,
causing.
and what you didn't know was that when a patient has an overgrowth with gram-negative bacteria, that it can evoke these severe spasms of the bowel that can be mistaken for napkin ring lesions, or can be mistaken for bowel obstructions. I've had patients who had gram-negative overgrowths who were worked up for bowel obstructions, and even had some who had bowel resections.
I was scheduled for surgery.
Who did not have a surgical condition, but had an overgrowth with a bacteria that was causing a spasm of the mesenteric muscles. And it wasn't recognized clinically because the doctors did not factor in that possibility. Because this part of the model of what is going on in the gut is not factored into medical
And they were,
training.
and no fault to their model or their training, they were doing the best within
No,
their framework.
it's
You
important.
just looked at it differently.
That's important because it is not antithetical to good medical training, nor does it conflict with what is taught in microbiology courses, or even in gastroenterology if you factor in all the information. It's just that when I do courses about this with doctors, it's important to me as a clinician that I try to point out to them where the errors are in their reasoning. And one of them is that when you order a culture and sensitivity on a stool in a hospital, you don't get a culture of the stool. What you get is they culture it on plates, and they put discs on it to identify Shigella and Salmonella and things like that, but they do not quantitatively, like, look at what actually grows. Now, if you do a quantitative stool analysis, what you can find sometimes is that the healthy flora, the ones that are supposed to be synergists, are gone or are suppressed, and that in proportion, these other bacteria, like gram-negatives, have overgrown, perhaps from a recent antibiotic or something. For whatever reason, their bowel flora is imbalanced in a way that evokes inflammatory molecules like histamine and kallikreins and so on, and it sets off the inflammatory cascade. And this is not taken into account when you look at things like autoimmune disease. And if you just order a stool culture in a hospital, you will not get a quantitative stool analysis. That's a key concept, because that is one of the things that shows when you factor in holonomics and how the bowel flora impacts the immunity in the brain, that is completely omitted from even gastroenterology. Now, there's a new concept in gastroenterology, I'd like to touch on this, called SIBO. And SIBO is small intestine bacterial overgrowth. And the premise is that if you get an overgrowth of some sort, which sure sounds like dysbiosis and a bowel flora imbalance to me, but anyway, if you get a small intestine bacterial overgrowth, that it can make the patient get really sick and cause irritable bowel symptoms and so forth. So, of course, they have a handy dandy brand new antibiotic that costs $1,000 a day that will completely sterilize the small bowel, and that is supposed to cure them of SIBO and the symptoms that go with SIBO. Now, to me, they've gone from one extreme to the other, and it is not true that the bowel should be sterile from the esophagus to the appendix. I mean, did they learn anything from H. pylori? I know there's supposed to be a flora there, and when it is distorted, that's when you have problems. Conditions like sclerosing cholangitis and even cholecystitis and an ascending infection from the bowel was not how it was taught to me, and yet it's the only thing that makes any sense if you think logically about how could an infection get up there. But see, why would it get up there is that you have an imbalance in the small bowel flora that spreads up there. And it's amazing to me that that's not how it's taught. But if you're a doctor and you're taught traditional gastroenterology, they'll just order a stool culture, and if these pathogens aren't there, you're taught that it's of no further clinical significance, and that is not true.
Or it's in the patient's head.
Well, one of the things I teach my medical students is, remember, if you can't figure them out, you can blame them. Tell them they're depressed. Now, I'm being sarcastic on purpose, but there's more truth there than you know. Doctors are routinely taught in chronic pain syndromes to try antidepressants because they help pain. But they really don't know why they're doing it. And yeah, there's a principle of osteopathy, and it's the body tends to heal. And what that means, you can change a system, and odds are it's going to feel better. So just because you give them serotonin reuptake inhibitors and raise the serotonin in the system, and they feel better, doesn't mean you've done anything to help the underlying disease process. One of the lines I try to throw in when I speak about fibromyalgia and spectrum disorder in national meetings is, you'd be depressed too if your doctor didn't know what was wrong with you. Now, this business about putting patients on antidepressants when they present with these types of complaints of fatigue and migratory joint pains and so on is what is taught. And 80% of patients who are diagnosed with depression have a medical reason to feel that way. And yet, this is not drilled into doctors when they put patients on antidepressants, that you better keep looking because there's probably something wrong. Patients have better things to do than pester doctors and hang out in waiting rooms. And it is arrogant of physicians to blame patients and call them depressed. It's a great way to get them not to come back. And I can remember myself when I was having dizziness and so on, when I was having some autoimmune, symptoms years and years ago, that when my doctor friends decided that there was nothing wrong with me because my tests were normal, they blamed me for it. They told me I was working too hard and that I was just, I needed to slow down and that I would, probably be better. But what was most amazing to me, because I'm a clinician too, and I'm a decent clinician, and I couldn't figure out what was wrong with me, I was going to them for help, which is not easy for me to do, to ask someone else to help me figure something out. And they got to the point where they quit. They wouldn't. And worse, they told me I was depressed, which is a way to get me not to come back to them. They're not going to help me figure out what's wrong with me. And I'd lost 35 pounds, and that factoid, which should have been like a reason to not drop the ball, didn't seem like it was any reason to them at all. And so I felt that they were abandoning me when I was sick, and that made me feel even worse because I already felt bad, and the last thing I wanted to do was say help and then somebody else say, well, I don't want to help you. And that's what it felt like. And many, many of my patients expressed that when they're being worked up for these symptoms and these problems, that there comes a point when they decide that the diagnosis is fibromyalgia where the doctor's eyes seem to kind of gloss over and they're no longer helping them with their condition, but instead they are managing their symptoms and their problems. I heard a person lecture at the AOA a few years ago in San Diego, and he was a pain management guy. And he gets up to talk about fibromyalgia, and the first thing he says is fibromyalgia is not very satisfying to treat because we don't know the cause of it and we only get to treat the symptoms. And I was floored. He had no idea that there were more than tender points involved in fibromyalgia, and he's an osteopathic physician lecturing at a national conference. And yet this is how this ignorance permeates the medical profession. As an osteopathic physician, immune dysfunction has reproducible and physiologically logical presentations like liver congestion and so forth, tenderness at the ileocecal area, other symptoms like that their cranial mechanism wilts and the vigor of the cranial mechanism is lost when they have bad brain fog, and how this correlates with other types of autoimmune diseases like Hashimoto's thyroiditis or rheumatoid arthritis or lupus, which are these chronic diseases of aging. Now, once you understand immune dysfunction and that it's reversible, your whole approach to diabetes, to thyroid disorders, to patients who present with endocrine disturbances, to insomnia, to depression, completely changes because you understand that these are manifestations of a dysfunctional physiology and not diseases unto themselves.